All this is Dr. Mobeen Sayed from DrBeen.com. Welcome to one more show. The discussion today is important. This is a follow up to yesterday's talk about the um, anti-idiotypical antibodies or anti-ACE2 antibodies after the COVID or vaccine. So, the discussion that we'll do today will be the therapies. So, let's start. Quick references. This is DrBeen.com. This is I Recover protocol on FLCCC. I had led this protocol, as I think many of you are aware of it. So this protocol is something that you should keep in mind as well. I'm going to talk about mainly the therapy directed towards anti-ACE2 antibodies. So the rest is over here. So I don't feel like I have to repeat all of this. So leave this, but I would focus importantly for this network hypothesis. And some of the comments I read yesterday were saying that this may not be possible. This is a hypothesis. So I have this this study over here. This study is September 3rd, 2021. It is published. I actually think that we should talk about this study separately. However, in this study, they say this is the first study where they were able to prove that anti-ACE2 antibodies are developed in COVID patients. So let me just very quickly go there for a second. It is actually a very, so if you read here, this is the first demonstration of anti-ACE2 antibodies in patients with SARS-CoV-2 infection. So that is now an understood mechanism that this is what is happening. Then they talk about multiple other things. The other part that I would like to discuss today is here at the end where they talk about possible management. So keep this in mind. It would be actually awesome to go through this paper. I would do it separately. When you get a chance, you look at that as well. In addition to that, now for therapies, more references here. This is a monoclonal antibody. That is, if you see here we report a human angiotensin converting enzyme 2, ACE2, targeting monoclonal antibody. So this may be an antibody that might be useful as well. So this is 2. Then these are a couple of non-authorized experimental drugs that have been tested in vitro or on animal studies to be able to work with ACE2. We actually do not have an approved ACE2 modulator. So the angiotensin receptor blockers are something else. I'll explain them. So here, dimenazine acetate, and then over here, xanthinone. These are the 2 experimental drugs that may be useful. And these 2 drugs are referred in this study to say, hey, we actually have molecular activators of ACE2, and they may be worth a try. Then the role of statins, and statins is part of the I Recover protocol as well. I would explain that today as well. Then what is an FC receptor, because we're going to talk about that today. What is the complement receptor and complement system? We're going to talk about that today as well. So these are the references. I'm going to now start the discussion. So today's discussion is going to stay very focused on the therapy. So welcome to the Humanities Coffee Shop. We are presenting the gifts of humanity together. So let's start. This is the Omicron time. And here, first of all, I got to do this because today we're going to talk about therapies. I have to present to you the medical disclaimer. This is not a medical advice. This is not a doctor-patient relationship. Please genuinely do not use this over the counter, these therapies. Some of the drugs that I'm going to discuss here can cause suicidal thoughts or even suicides. So please be very careful. The use of this is educational And then you can discuss it with your doctor if they are open to listening, and say, here are some person who has combined the various potential therapies in one place. So we have done their legwork. They can then go through this and decide how do they want to manage. So let's continue. So this discussion is an exploration of the mechanism. So the discussion I'm going to do is, here is a mechanism and here is a therapy. Not a medical advice. It is useful for your provider, and this is by far not an exhaustive list. I'm sure that there are more mechanisms, there are more issues, and we'll talk about them as well as they unfold. For the time being, this is an additional mechanism to the previous long haul talks and therapies. So the important thing here is, so if you think about it, whatever pathologies you would see, a result of all of them is inflammation. Our body's final common pathway of usually responding to a problem is usually inflammation. So because inflammation is a final common pathway, it is important to look at inflammation first. Now, there are doctors which have differing approaches. Some doctors say, I would like to take care of the basic pathology before I take care of the symptoms. That may be okay, where you can quickly understand the pathology and take care of it. If understanding and exploration and discovery of the pathology, the mechanism which is disturbed, is difficult to find, then symptomatic treatment becomes important. In case of post-COVID injuries or post-vaccine toxicity, as the Harvard and UC Davis's professors had mentioned yesterday, in those cases, it is important to start anti-inflammatory early on. This is a 1.5-year-old discussion. To start anti-inflammatories or steroids early on, so that while you're figuring out what is wrong with the patient's mechanisms and how to manage them, you keep the inflammation levels low so that you don't cause or you prevent any damage. Can I give you an example of damage? Yes. For example, we know that inflammation would cause the T cells and B cells and the other immune cells to arrive at the site of inflammation and start doing destruction. That can cause destruction of, let's say, pancreatic cells, beta cells. That can cause destruction of cardiac cells. That can cause destruction of around the blood vascular tissues. Remember the monocyte carrying the S1 protein and leaving or releasing cytokines around the blood vessels. They can cause local inflammation and cause neurotoxicity. The nerves that come out of the skull, they pass through very tiny holes or foramina. If they are swollen and they get trapped, they can become permanently damaged. So one job of the physician or provider is to make sure that inflammation is less, so that permanent damage is not occurring while we are figuring out what is going on and helping with that. So, but again, for everybody, there has to be a thinking. For example, somebody is diabetic and you give them steroids or not. Or, for example, somebody has infections and you give them steroids or not. So, there is case to case difference, but there is a basic approach to curb the inflammation first. So, now I'm going to be specifically working with the anti-ACE2 antibodies. This study that I showed you, they actually saw 93% of the patients had anti-ACE2 antibodies. Majority of the inpatient, that is hospitalized patients or severe cases, had anti-ACE2 antibodies. Fewer in outpatient. But in all cases, 93% of the cases, they had anti-ACE2 antibodies, and they saw that they recovered as well. And they recovered, these waned, just like the antibodies from vaccines wane in 5-6 months. That means if there is a negative outcome, it is possible that in majority of the people, within a few weeks to 5-6 months, it would go away. But in some people, it continues to linger on for longer. Okay, so please recall yesterday's discussion. Here is a cell. The cell has ACE2 receptor on it. This has gotten this antibody bound to it. That is the anti-ACE2 antibody. correct? Or anti-idiotype antibody. Once it binds, what happens is that this process of binding an antibody to a receptor or to a cell surface is called opsonization. This allows the immune system cells, especially macrophages, dendritic cell, but other cells too, neutrophils as well, for example, mast cells as well. It allows these cells to be able to grab the open end or the fraction crystallizable or fraction constant FC part of the immunoglobulin and eat up this cell or phagocytose it. So opsonization is making a target easy to eat, and antibodies do that. So as soon as the antibodies are coated on the cell, why is the cell sad looking? Because he knows he's going to be in trouble very soon. So the macrophages would come around, they would phagocytose it and destroy it. In that process, when the macrophages are going to phagocytose and destroy it, they will become activated as well. They would release cytokines, they would release chemokines. And now, please remember, macrophages do not automatically become activated. Most of the time, they would eat up something, they would then release chemokines and cytokines that would cause other cells to release further cytokines and chemokines that would activate the macrophages. An example is adaptive arm releasing interferon gamma that would cause the activation. So, cytokines and chemokines are released. Antigen presentation starts occurring. Remember, macrophages and the dendritic cells, they can pick up an antigen, break it up, and then present it. When the antigen presentation would occur, of course, that would cause innate and acquired arm to start becoming activated as well, and inflammation start as well. And this is very important, affinity maturation would occur. This is follicular dendritic cells. What happens is when a follicular dendritic cell picks up an antigen and presents it, it causes the B cells to become even more refined in their behavior. So here we are talking about an antibody that is going to attack our ACE2, and now we are helping refine that. So that would become an issue. Then, of course, if it is a microbe, then the destruction of that. The takeaway here is that when an antibody is connected with a pathogen or with our cell surface, it will mark that thing to be destroyed. And when the destruction is occurring, immune system is becoming activated as well, and inflammation would occur. Then, of course, that would mean macrophage activation would occur, mast cell activation would occur, and so on. Then continuing. Here, once again, the same cell, antibodies are connected with it. These antibodies, when they connect, they do one more thing, and that is they activate the complement system, or they start a complement cascade. What does that mean? What that means is that antibody has to first land somewhere. Imagine if antibody was a spaceship. It has to land somewhere. So here it has landed on this cell, unfortunate cell. Once it lands, the antibody opens up its doors. So there are areas on the antibodies which start opening up for a conformational change after a conformational change. So there is a change that occurs and the doors open on the antibody's constant part. Those doors allow complement proteins, which are another set of proteins produced by the liver, and these are part of our innate immune system. These proteins would come and attach there. So imagine when the spaceship lands and the doors open, the astronauts, instead of coming from inside towards outside, there are more people who are going in. But they're really not going in, they're just attaching at that open door. That is complement system. Once the complement proteins become activated, that is even more disaster for this area in this cell. Why is that disaster? Because, and just give me 1 second. I want to make sure that I am Okay, so everything is good. So back here, I thought for a second that my audio video was not working correctly. So back here, those complement proteins, when they are activated, they themselves start a cascade of events. The end result of those are a couple of important parts. One is, if you see here, this is this is a membrane attack complex. So the complement proteins, they start becoming active, they start becoming cleaved, they start making little crystals, and then they all unite together and they make a tiny pore in the surface of the cell. They land on it. This is why it is called a membrane attack complex. That attack complex lands on the cell surface or the microbe surface, whatever, fungus, bacteria, even in case of enveloped viruses, virus. And that allows a pore or a hole to be formed in the cell or this structure, and that would cause things to start spilling out, and this thing is going to die. This cell, this microbe, this bacteria, fungus, whatever it is. In addition to that, as part of the complement activation, there is a protein produced that is called C3b. So normally the complement proteins are called C1, C2, C3, C4, and so on. When they become activated, they become usually split into two. And then one part is called A and the other part is called B. We also say C, A is for action and B is for binding. Anyways, just for our discussion, two parts. The C3b, when that is formed and that sits on the surface of the cell, to remind you, we have, let's say, a patient of COVID-19 or someone who had vaccine, then they unfortunately developed anti-ACE2 antibody. That antibody connected with their cell, that through ACE, the result is activation of the complement system. Now the membrane attack complexes are forming, plus C3b is forming. This C3b is now sitting on the cell surface, and once again the cell is scared. Why? Because C3b is also an opsonin. It is also something that would allow the macrophages or others to eat up this cell. I say that when I'm talking with medical students or doctors, I say that this is the sweet tooth macrophage has for immunoglobulins and for C3b. So as soon as macrophage sees C3b coating a cell or whatever surface, bacteria, fungus cell, it eats them up as well. When it eats them up, then the same problem or cascade starts. And that is, cytokines are produced, chemokines are produced, antigen presentation occurs, affinity maturation can occur, microbe destruction would occur. And one more important thing, that is, when these cells are now being destroyed, then the local destruction or destroyed tissue debris is produced. Right? Imagine these are tiny little houses and we are wrecking them with the wrecking balls and we are destroying them. So that would create a lot of debris. That debris is called damage association or associated patterns, molecular patterns. So there are broken bricks, molecules, broken pieces of cell membrane, broken pieces of DNA, RNA, ribosomes. Those things are just sitting around. This is like if you break a glass and it is, the pieces are on the floor. So those broken pieces of the damaged tissue are called damage associated molecular patterns or DAMPs. And if there is an auditor who's listening to my video and is going to say that Dr. Mobeen used the word DAMP as a damage associated molecular pattern and it should have been DAMP meaning wet. So please, this is medicine. DAMP here is damage associated molecular pattern. When that happens, the DAMP, then the immune system cells also have receptors for DAMPs. So they are called DAMP receptors. Macrophages have them, So macrophages are always touching the floor and feeling any damage associated patterns. For example, imagine if I become a little gross, an animal died and the brains are out and all that on the road. You can look at that and say this an animal is damaged. There is a pattern, there is blood and the squished body and the brain is out, right? Similarly, macrophage is looking around for our cells, and it can see a cell's brain out, DNA out, and the cytoplasm out, and the membrane broken. And it can then say, there is something wrong happening here, and I'm going to become activated. Now, this something wrong could have been done by the macrophage itself. The macrophage would have probably picked up the cell and destroyed it. Anyways, immune system is now becoming active. Then so the previous set of mechanisms that you saw, they all would cause inflammation. Now, this set of mechanism that you would see is when this antibody, so give me your attention for 1 second. I'm going to start from here. Start from your liver. Your liver produces angiotensinogen. It produces a protein called angiotensinogen. Your kidney, my kidney, produces another molecule called renin. Renin cuts the angiotensinogen. This is like you have a friend who makes some paper and you have a scissor and you cut that paper into multiple pieces with that scissor. When the angiotensinogen is cut, it is now called angiotensin 1. This angiotensin 1, that cut paper, when it is circulating in our blood and it goes through the lungs, on the lungs cell, and that is what I've made here, on the lung cell, there is an enzyme on the cell surface called ACE, angiotensin converting enzyme. We have done this discussion in detail last year, multiple talks. So I'm just staying at the high level. ACE enzyme is present that will take angiotensin 1 and convert that into angiotensin 2. This is a very important system for maintaining blood pressure and blood volumes and many other things. So, when angiotensin 2 is produced in the lungs by conversion of ACE, now please pay attention here because I want to clarify why angiotensin receptor blockers are not helpful. So, angiotensin 2 now functions on target tissues. And if you see here down at the bottom, there is this cell lying down. This cell is, let's say, an endothelial cell, a blood vessel cell, or the smooth muscle of a blood vessel, some target cells. On these target cells are receptors. These are called AT1 or AT2 receptors. Angiotensin 2 molecule acts on these receptors and causes its effect. What are the kind of effects? It can cause hypertrophy of the cells. So that means in some cells, when it acts on them, it causes them to become bigger and stronger, like a bodybuilder, hypertrophy. It can cause inflammation. And we have done this discussion in the past how inflammatory molecules are produced under the influence of angiotensin 2. It can cause local fibrosis. And that can sometimes be bad. Sometimes it is good. But sometimes, for example, lungs, when they start getting fibrosed, they start losing their volume and their capacity to become elastic or to stay elastic. So fibrosis occurs. Vasoconstriction occurs. That is usually useful to increase or maintain the blood pressure. Cell proliferation occurs. More cells are formed. So you can say that angiotensin 2's function is pro-inflammatory plus elevating the blood pressure. Good. This angiotensin 2 molecule, while it is circulating, it is really important for us to remove it from our system. Otherwise, it would continue to do this action and continue to cause inflammation and continue to work with the blood pressure. So on other cells, and we know kidney cells, GIT cells, heart cells, lung cells, brain cells, there are cells with the receptor ACE2. And we've been talking about ACE2 for 2 years now. That is the receptor that is, or enzyme that is used as a receptor by SARS-CoV-2. This enzyme here, this ACE2 enzyme binds with angiotensin 2 and sort of deactivates it or converts it further. It converts it to angiotensin 1 to 9 or angiotensin 1 to 7. These molecules, 1 to 9 or 1 to 7, they in turn work on a receptor called MAS receptor. And I discussed the name, why we call it MAS, in a previous video. But the outcome is antihypertrophy, meaning instead of increasing the size, not increasing the size. This is important, anti-inflammatory. ACE2's normal function helps reduce inflammation. Antifibrosis, so damage to the lungs, damage to the blood vessel and the tissues around them, that might actually become a permanent damage in a long COVID patient or post-vaccine toxicity patient. The ACE2's function can help prevent that. That is its normal function. Vasodilatation or dilation, and then anti-proliferation. So many counterbalances to pro-inflammatory system. So I think you can see that if we have the ACE2 blocked, why blocked? We have an ACE2 antibody attached to it. Then we saw in the previous section that there was inflammation that was occurring, cell destruction that was occurring. Here we are seeing that when you block the ACE2, then this angiotensin 2 will not have a way to be converted or destroyed, let's say. And that means we would start piling up angiotensin 2. That means angiotensin 2's function would start increasing. And we would have extra inflammation, and we would have extra increased blood pressure, and we'll have extra hypertrophy and extra fibrosis and extra damage. So these are two primary mechanisms that we should look at from therapy point of view. So now let's look at the therapy. The benefit of looking at the mechanisms and then therapy is that we can actually think about it instead of just cramming that how to handle it. So first of all, steroids. Steroids are interesting and important because regardless of what is the mechanism, for example, S1 protein in monocyte, for example, blood cell shape differences, or for example, ACE2 antibodies, or we have talked about other mechanisms in the past as well. They all would cause inflammation, and steroids would help keep the inflammation down. The benefit of that is that permanent damage that can occur is prevented. It is kept in check. Number one. Number two, now antigen antibodies. So antibodies against anti-ACE2. Very simple. This is why, and this study that I have shown you, in that study, authors say what I said yesterday, that sometimes people who have anti-ACE2 antibodies, they receive a vaccine and for some months they say we feel better. Why? Because vaccine, when it arrives in our body, it will produce the mirroring antibody, which is supposed to be against the spike protein. And here, this antibody that we are discussing is kind of acting like the RBD of the spike protein. So those two antibodies would bind with each other and clear out, and patient would feel better. But if underlying the autoimmune part that has already become triggered, if that continues, then when the effect of the vaccine goes away, then the other effect would surface again, and the patient would start feeling bad again. But there are therapies. So now this is not an approved therapy. This is an experimental therapy. This is 3E8 antibody. And let me show you where it is. That means if you are unfortunately struggling with this, keeping an eye on these therapies is important. So here we report a human angiotensin converting enzyme 2 targeting monoclonal antibody 3E8 blocked the S1 subunit and pseudo-typed virus construct from multiple coronavirus, including SARS-CoV-2. So they actually used this to say, can we block the SARS-CoV-2 from connecting with the ACE2? Now, of course, there would be a question in your mind. If we try to have antibody that binds with the ACE2, would that do the same thing that this one does? So far, that monoclonal antibody, their experiment has to tell what are the side effects and do they see this? Number one. Number two, will that cause unavailability of ACE2? So the angiotensin 2 continues to stay high and has its own deleterious effects. So that would have to be looked at as well. But that is a therapy available. Then vaccine generated antibodies, as I discussed. Then infection generated antibodies, again, I would not recommend infection to anyone, but this is true that people who develop infection sometimes say, I feel better. Long haulers who develop infection, they say, hey, I'm actually feeling better. Other monoclonal antibodies may be of use as well. Those monoclonal antibodies that are made to clear out these antibodies or to replace them with the ACE2. So now you may have one more question in your mind. What tells that this antibody binds with the ACE2 or another antibody binds with ACE2? What determines that? Usually it is the affinity and the concentration. So if you give another antibody that is in a greater concentration, then that will win and this will not. Then intravenous Ig, immunoglobulins. Intravenous IGs can help clear out those spurious or abnormal antibodies that are circulating. However, I was talking with Sean, you have met him before. He was thinking about, so he's going through some therapies as well. I would really request him at some point to join us again. And he was thinking that his experience has been that it exaggerated his situation. And that might be because the IVIG nowadays already has post COVID patients' antibodies in it, which may be causing the problem. So that means it is a good option, but one will have to try it to see how does it work. My thought is that when IVIG is given, then it is natural that that IVIG or intravenous immunoglobulins or even subcutaneous immunoglobulins might bind with the other antibodies, and that binding might cause inflammation as well. So it may be necessary for a physician to give a low dose steroid therapy while using IVIG to make sure that if any inflammatory relapse is occurring, that is controlled with steroids. Then this is a drug that I think we all know about because it binds, and we have seen that study, it binds with the SARS-CoV-2 spike proteins RBD area. It is possible that this can bind to this antibody as well. And we also know that it can bind to ACE2. So if it is in good concentration, then it can block the ACE2 from being used by this antibody as well. So this is another potential therapy. Then plasmapheresis. What you do is you bring the blood out from the body through a machine, you separate the plasma, then you remove the abnormal antibodies from it, and then you put it back. This is a very common practice where it becomes absolutely must because other things are not working. So plasmapheresis is a valid possibility to work with this one. Then intermittent fasting to promote autophagy is a possible mechanism because, and you would see this, so everything I'm speaking, I have backup in those references. The study that I just showed you, this one, this study or this paper, they actually talk about it here. Look, this again, so this mechanism of immune response and creating anti-idiotypical antibodies or anti-AS2, for example, in this case, they say this again is consistent with Jern's theory in that immunological control mechanism should typically limit production of an autoimmune antibody, which could result in the disease. So what they're saying is this antibody against the antibody that is produced is actually a homeostatic mechanism. It's a controlling mechanism. It's a clearing away mechanism. What does that mean? I became infected. My body responded and created a bunch of antibodies. My body also knows to regulate them now. So it is worried that, hey, I've made too many antibodies. This person is going to become sick of the antibodies. So let me make another set of antibodies that would clear these out. And then there would be a balancing act, and slowly both of those would ramp down, and those extra antibodies produced against a pathogen will be cleared out. So it is possible that if you give immune system enough time, these cells would clear out automatically. And these cells usually have time. They have lifetime to live and then they die. So if you allow with, let's say, steroids, enough time, then you are actually not asking steroids to go help you other than controlling the inflammation. You are waiting for the cells to die out. Meanwhile, they're going nuts, the cells, and you're giving steroids to keep them in check. You know they're going to die in 2 months or 3 months, and you're saying, okay, fine, I'm going to give steroids to keep it in control while these cells are flaring up, and then they're going to die. On the other hand, if we don't control the inflammation, the cells would keep activating each other and making copies of each other and continue with this bad behavior. So whichever way you can rest the immune system, by giving steroids, by intermittent fasting is known to create or promote autophagy, or simply apoptosis in cells, or the immune cells killing themselves, which is a normal mechanism. Killing of a cell that is active and then when it is not needed is an important function. And here, when we're talking about these things, it is when that function has become abnormal. And I know yesterday many folks asked that how can this happen when our cells are trained not to attack our cells? So I'll talk about what are autoimmune disease mechanisms tomorrow. But today, let's assume this happens. And here we have a study that proves it happens. Yesterday, we talked about a possibility. Today, we saw a study that does. Now, let's look at the therapies. So if you give enough time, it can go away. But to give enough time, you have to make sure that the damage is prevented. And so for that, you're giving steroids and other anti-inflammatories. So intermittent fasting may be useful. Rest the immune system in whatever way you can. So for a physician, they may have a bunch of things. They can give steroidal anti-inflammatory, they might give non-steroidal anti-inflammatory, they might give some other targeted monoclonal antibodies against the immune system like leronlimab or maravirox or others. But eventually, you're giving the immune system enough time to clear out the bad cells. Then, as I showed you before, recombinant soluble ACE2 can help. So this is something which I remember my dear friend from Greece, Dr. Alexandros Vasaras. Dr. Vasaras, I hope I'm pronouncing his name clearly. He's a celebrity in Greece for his work in COVID. He had 1.5 years ago, in one of these sessions, said, why can't we make soluble ACE2 as a decoy and inject that to allow the SARS-CoV-2 to connect with that, and that way reduce the severity. So here, these authors, the paper that I'm showing you, they said it is possible to make recombinant ACE2. That means ACE2 from, ask a bacteria, give them the gene for the ACE2 and ask them to make ACE2, and then inject ACE2 in our body, and then allow those ACE2s to become the target of immunoglobulins. Now, I know that you would have this question that, hey, having those extra ACE2, aren't they going to become target of an angiotensin 2 as well? Yes, our body is very good with the molecules. If a molecule is used up extra, body can make more. If it is not used up, body can regulate it itself, unless we see these kind of abnormalities where the regulating system itself is damaged. So if we give soluble ACE2, there is a possibility of this kind of a situation to become calmed down. And once again, you calm it down, you reduce the immune system's behavior, you reduce cytokines and chemokines and continuous fire and the fuel, and the immune system would start becoming reset and the cells would start dying out and clearing out. So that is also possible. Then these are experimental therapies, the small molecule activators of ACE2. I still have to talk about ARB, and I'll talk about that in a second. This is the activators of ACE2. We actually do not have a therapy to activate them. The therapies that I showed you in the beginning, these are experimental, and these, one of them is in vitro, the other one is in rats. So they are still not available, but important to keep an eye on. Okay, so that is one set of possibilities. Then if I continue, now one more thing here. It is possible that these can cause flare-up. Do you know why? When you have another antibody binding with this antibody, that would make a complex, immune complex. That immune complex is going to now tumble around. Imagine there are two people who hug each other and roll down on a skiing slope, and now they're just tumbling down. Antibodies sometimes connect with each other or connect with an antigen, and they just tumble around, and eventually they go and get settled on some tissue, many times kidney. And wherever they settle, the complement activation and the macrophage activation would occur, and that tissue would be damaged. So many times the antibody complexes end up on the kidney filtration system, where then the immune system become activated and start damaging the kidney. So remember that these giving antibodies against antibodies could produce those complexes, which means you still have to support them with steroids so the inflammation doesn't get out of hand. Because what we are not trying to produce is inflammation. We are trying to clear out the antibodies. We're not trying to say, I'm going to clear it out and also cause lots of fire in the body. That's not what we need. We just need a mop to clear them out. Okay, so continuing. So if you look at this stage, where the macrophage has become activated, so of course, macrophage activation modulators, vitamin C's, vitamin D's, melatonin, statins, these could be given. Then mast cell could become activated, or mast cell activation syndrome can become unmasked. We have done this discussion many times before. And so for them, histamines and cell stabilizers and so on, those can be given. Continuing, CCR5 blockers, ranties, Dr. Bruce Patterson's favorite word. So that maybe leronlimab, maybe miraviroc, maybe something else. So that is a more targeted modulator of the immune dynamics. And there are other drugs as well that may be tried, because at the end of the day, it's going to give a rest to immune system and reduce the immune responses. Then, of course, uh, fluvoxamine. Fluvoxamine in some patients can actually exacerbate the situation. Sean had mentioned that fluvoxamine actually exacerbated it. My wife took fluvoxamine, and that actually increased her situation as well, made it aggravated. So it's not necessary that it would help everyone. Then low dose naltrexone, I am seeing that that is one of the most successful therapies, low dose naltrexone. Once again, these drugs, low dose naltrexone or fluvoxamine or other, because they are drugs that would act on brain, they can cause serious harm as well in terms of psychological and mindset. So please, please, please don't take them over the counter. Talk with your doctor, discuss it. They know what your situation is, and then decide. So fluvoxamine, try and decide with the doctor's help. Statins, this is another one. So statin have a couple of interesting helpful mechanisms. One of the mechanism is anti-inflammatory. So fine, we have statins that can be anti-inflammatory, we have other anti-inflammatory as well. But there is an additional mechanism that in the case of anti-ACE2 will not be useful, but it might be useful where other spike related mechanisms are in play. And that is, hear this out. And I have a reference for that. So just like Apple says, I have a app for that, I have references for that. So statins reduce COVID-19 severity, like removing cholesterol that virus uses to infect. So here we have a study in which what they did was they saw that, remember the virus. So we are talking virus, we're not talking about antibody, because antibody doesn't do it. So this would not be an action for antibody that we're discussing today, but just interesting for you to keep in mind as well. So we know that if this is a cell and the virus binds here, right, ACE2, then what would happen is the priming would occur, S1 would separate from S2, the S1 and the receptor part would become internalized and downregulated and recycled. ACE2, the S2 part, I called it ACE2, S2 part would then connect with the cell membrane. Then the whole virus's membrane will fuse with our cell membrane. And that is how the mRNA would get into the cell. This fusion of the virus's surface or envelope with our membrane needs our membrane to be fluid, to be permissible, to be able to permit this fusion. And if our membrane is a little rigid, has less, the fluidity comes from cholesterol. So if you remove cholesterol, the fluidity of the cell membrane would become less. This is why reducing too much cholesterol can make people's skin rough, because the fluidity and the flexibility comes from cholesterol. So when that fluidity is reduced in the cell, then the virus would find it difficult to fuse with this hard membrane. And that can help as well. So again, but that is the virus, not for this discussion. But still, that means just hearing that statin can help doesn't mean that they would help in all cases. So here, try if it works good, otherwise not much use. Now I'm going to go to the angiotensin receptor blockers. And you would see tons and tons of studies or hypotheses to say, we think angiotensin receptor blockers will help. So I want to make sure that we understand where can they help and where can they not help. In the discussion today, we're talking about anti-ACE2 antibodies. That is antibody binding here with the ACE2, correct? Now, angiotensin receptor blockers, what they do is they bind with 81 or 82, and they reduce the role of angiotensin. They reduce the attachment of angiotensin by occupying 81 and 82. They do not bind with ACE2 enzyme. So that means ARB actually are not useful for directly modulating ACE2 enzymes behavior. So then, are they useful in some other way? Yes. What is that way? That way is that when angiotensin 2 is produced, we are banking on ACE2 to kind of further modify that and make it angiotensin 1 to 7 or 1 to 9. And the angiotensin 2 will disappear because it has become angiotensin 1 to 7. So the function of angiotensin is reduced when we convert it, and that conversion is done by ACE2. Now imagine if ACE2 is not doing the conversion because ACE2 is occupied by the immunoglobulin. Then angiotensin has increased in amount. If it has increased in its amount, it's going to create side effects. by being more in volume and attacking more on the AT1 and AT2, or attaching more on AT1 and AT2, to reduce that extra behavior of inflammation and of vasoconstriction, etc. We give angiotensin receptor blockers to reduce the target effect. We can't reduce this molecule, but we can reduce the effect of that. So ARB cannot block the antibody from binding with ACE2. That would not help. So angiotensin receptor blockers are not going to help against antibody binding to ACE2. But they are going to be helpful to reduce the extra effect of angiotensin 2, which is accumulating because ACE2 is not available. So useful directly against the antibody, no. But helping to reduce the symptoms, yes, because out of all the symptoms of long haul or all the symptoms of post-vaccine side effects, this set of symptoms of vasoconstriction, inflammation, hypertrophy, what is that? Cell proliferation, inflammation in general, fibrosis, that all would become part of the symptom set. So hopefully that helps. Then, this is important. Maybe we can downregulate the ACE2 enzyme itself. Now, there is a potential bad thing. If you downregulate the ACE2, then the function of ACE2 would become less. How do you downregulate the ACE2? Give antiandrogens. We have done a complete discussion about that in the past. Give antiandrogens. Antiandrogens, one of their function is to modulate the production of TMPRSS2 and production of ACE2. Now, some folks said to me that, hey, TMPRSS2 might be useful. I actually read a study where they said giving antiandrogens would cause TMPRSS2 to become downregulated, which will help against the long COVID. I think that would not help if it is this mechanism. The other mechanisms would help. Why not? Here is the reason. TMPRSS2, its function is priming of the spike protein. But here the disease is not because of the spike protein, but a thing that looks like spike protein, and that is antibody. So you don't need to prime the antibody. So even if you downregulate the TMPRSS2, the antibody is still going to attach to the ACE2. So TMPRSS2 modulation would do nothing. However, ACE2 enzymes downregulation will help. So antiandrogens will help by reducing the ACE2's enzyme density on a cell, which would also mean that once you do that, so I'm talking with the doctors and providers, once you do that, you are going to cause angiotensin 2 to increase, which will cause now a separate set of issues. So imagine a patient comes to you, you suspect that it's maybe ACE2 antibody to ACE2 issue. You give androgens thinking ACE2 would go down, and you think it should become better. Now inflammation should be less. But instead, you saw the inflammation increasing. Why? Because now angiotensin 2 has increased. And why has that increased? Because ACE2 was occupied or not present. So it did not work on angiotensin 2 to convert it to angiotensin 1 to 7 or 1 to 9. So now we have more angiotensin 2. So you have helped this side of the inflammation, but this side has now increased inflammation. So what do? In addition, maybe give ARBs. And if you're not comfortable with the ARBs because they can modulate blood pressure, then give steroids. If you're not comfortable with steroids, then give some other anti-inflammatory. Otherwise, you would reduce the inflammation from one mechanism and you would increase inflammation from the other mechanism. This is why I have always believed that when you're managing the long COVID or post-vaccine effects, a baseline steroid is necessary to keep inflammation in check while you are tackling the other pathologies. So I hope that this makes sense. This is the discussion for today. I went on for an hour. I always think I'll do this in 10 minutes, and then here we are. Thank you very much for listening in. Today, we would just do one talk. I have a family dinner together, so I want to spend some time. We'll continue tomorrow. I have a lots of important things to discuss. Uh, so please do me a favor, like, subscribe, and share. If you don't want to add this channel into your subscribed channels, then just like the video. That would help. And if you would like to support this work, then you can use the links in the description. There is a link for buying me a coffee. There is a link for using PayPal, or you can become a patron as well. So thank you very much. I think at this juncture of the pandemic, this set of therapies together in one place is a very important set. I hope YouTube doesn't take it down. I hope um, it can stay up and be valuable, but it is a very, very important talk. And I hope that you get some value from this. Thank you very much. And I would see you tomorrow.